Okay. Thank you very much, and thank you, colleagues, for your patience as you work through these technical issues. We have a PDF version of my presentation. Unfortunately, there was some sort of dynamic graphs that I wanted to show you, which I won't be able to, but for the sake of time, that may not be the worst thing. So thank you. I'm going to be looking at a range of countries on our continent, lessons that potentially can be gleaned from their rollout processes and challenges. Next slide, please, Taryn. So I think the first thing to say at the outset is that country-specific vaccine administration, distribution, and acquisition is clearly not enough to end the pandemic, and that's because of one simple reason, and that is the pandemic is a single system threat. So, and that system is the globe. So a national or a regional epidemic would require a response and analysis at that level. The single system is a globe, multi-layered and as complex as it is, and therefore we need to be a bit agnostic about political barriers and see one bounded system as being the globe in dealing with this pandemic, and that includes the priority of a universal access to COVID-19 vaccines and an equitable rollout. Now, the above notwithstanding, there is still value, of course, in doing analysis at country level, especially if that analysis helps to reveal the extent of disparity that exists between countries, within and between regions. And so there is some utility in what we're doing here. We've selected 5 countries to very quickly give a synopsis of in terms of their rollout processes. And these 5 countries are Egypt, Ethiopia, Kenya, Nigeria, and South Africa. Now, they've been selected for 2 reasons. One is that they represent as a group a very large part of the continent, not just in terms of economic activity, but more importantly in terms of population size. We're looking at about 40% of the population and half of the GDP of the continent. The other reason is that an analysis of these countries formed a part of a report, the Epidemic and Pandemic Response in Africa, a PRIA report that was done in partnership with Columbia University and also Brenthurst, and was presented at a recent Schmidt Forum. I contributed to that report, specifically looking at these 5 countries in terms of their acquisition capability, their manufacturing of vaccine capacity, as well as their rollout preparedness. Now, we won't go into those details in this presentation. What I'd rather like to do is just give just a high-level overview of where we are with rollouts in these countries, and then have a view of specifically vaccine equity questions that need to be raised in each country, and giving examples of that. Next slide, please. So yeah, this is a very familiar map. In the PowerPoint version, it's a dynamic map. So I reverse to the beginning of the rollout process and show over time in subsequent slides how we've seen the rollout process. But commentary has really spoken to the slide, and I think the message speaks for itself. The picture speaks for itself, and that is just a picture of inequity in terms of the global rollout. Next slide, please. Great. So let's take a helicopter view of the 5 countries and have a baseline of sorts. So this baseline is used very loosely here. Really what we're looking at is a starting point pre-pandemic, pre-COVID-19 pandemic of these 5 countries using the lens of global health security. So these are data from the Global Health Security Index in 2019. And they have different parameters. So each parameter you see has subsets or components. For the sake of time, I won't go into that detail. We can always maybe discuss it as we go on in the Q&A. But these are selected sort of parameters. So looking at immunization, it's important to just understand the interpretive lens here. There are 2 dynamics to here. One is the global average. So about 170 countries have been analyzed. And what is the global average? And then the color coding is a score allocated by the GHS team that split it up into thirds: low, moderate, and high scoring. And what we see is very interesting. We see a relatively good capacity in immunization, and the measure there was really around vaccination rates. But then globally, that was a high score. And then we move on to the next 2 columns. Very interesting to compare these 2: health facility capacity vis-a-vis healthcare access. And these two aren't necessarily correlated. In fact, we see in most instances that there is either high capacity or moderate capacity, but poor access, or vice versa. And it's very interesting that those two didn't tie together. Of course, both are critical in any vaccine rollout process. The next is the epidemiological workforce. Again, we see a fairly mixed picture, although not too bad. And specifically looking at Kenya's epidemiological workforce is fairly robust. Emergency response and cross-border agreements in terms of health emergencies, the same score for all 5 countries, and poor in terms of emergency response operations, the capacity on the ground generally, and then moderate in terms of the cross-border agreements, which again is very important in a single system threat like the COVID pandemic. The last column is from a different data set, and that's looking at which countries had vaccine manufacturing capacity before the pandemic. There are 8 vaccine manufacturers on the continent. 5 of these are in these 5 countries, although one country, Nigeria, has 2. And then, of course, we've got Egypt with Vaxera, the EPHI in Ethiopia, and BioVac in South Africa. So this gives a bit of a picture of where we were at the beginning of the pandemic in terms of readiness. Next slide, please. So really, just for the sake of time, again, to give a high-level overview of each country. So where we are now in terms of Egypt, and the disclaimer, of course, for all 5 countries is that this changes by the hour. We have updates all the time, and so some of this information may in fact be very stale. But this is where we were in terms of the preparation at the preparation point of the presentation. Sinopharm was the main vaccine rolled out. It is a main vaccine rolled out in the Egyptian context. With 350,000 doses, and then through COVAX, the AstraZeneca vaccine with 50,000 doses. On the 24th of February, the Egyptian Drug Authority, the authorizing body in terms of medicines, also approved the Sputnik vaccine. The frontline workers were commenced in terms of vaccination at the end of Jan with Sinopharm. And currently, Egypt has 40 vaccination centers and has just started on the 4th of March a wider rollout beyond frontline workers. So vaccine equity consideration, these are both positive and negative. In this instance, positive. Hala Zayed, the health minister, has been very vocal in advocating for a more equitable rollout. As far back as October last year at the WHO Regional Committee meeting for the Eastern Mediterranean region, she made a very strong call, as have many other health ministers, for vaccines to be made freely available to poor countries. And I think that's an important point. Next slide, please. In terms of Ethiopia, Ethiopia received 2.2 million doses of AstraZeneca Oxford vaccine via the COVAX facility on the 7th of March. And it plans to start the rollout process as soon as, obviously going through the due diligence in the initial phase. It has shown, very importantly, considerable capacity for rollout processes in terms of vaccine, in that in the middle of the COVID-19 pandemic, it was able to, through a very well-organized campaign, vaccinate 15 million people against measles. And I think that says a lot to its capacity. However, it does face a number of serious domestic challenges, most notably the conflict in the Tigray region, and that would have a knock-on and indirect impact on the domestic infrastructure of the country, including its health infrastructure, which may impact on the rollout. Vaccine equity consideration. The Duke did a very interesting study in November last year, analyzing the acquisition capability or acquisition pathways for different countries, and it found that in the case of Ethiopia, the only pathway at that stage was via COVAX, and even then, the acquisition was only going to be for 20% of its population, with no alternative seen at that stage. And that is a very real example of the kind of inequity we're seeing from a country level perspective. Next slide, please. Kenya has received just over 1 million doses of AstraZeneca, again via COVAX. And you'll see that AstraZeneca will most likely be the most common vaccine in circulation by the facility at this stage. The country has, like in the South African context and in many contexts, a 3-phase rollout plan with a staggered rollout on phase 1, phase 2 focus on the more vulnerable, and then phase 3 on people with other vulnerabilities besides those that have been considered to be the most harmful with regards to COVID. What is important to note, though, about the Kenyan example is that its current plan only will see, if it's fully implemented, 30% of the population receiving the vaccine, and that only by mid-2023. And I think that is very disconcerting. And the reasons given are both funding and availability limitations. And here we again see the distorted face of vaccine nationalism, hoarding, and scarcity of resource on the global stage. And it is very worrying. Next slide, please. In Nigeria, we have seen just under 4 million doses, again, of AstraZeneca via COVAX arrive on the 2nd of March. The first batch of 16, this will be the first batch of hopefully 16 million doses to arrive. Once the drug authority has gone through the due diligence, we would possibly see a commencement of the rollout tomorrow. That was the initial plan. In addition to that, AVAT, the African Vaccine Acquisition Task Team, has managed to secure 42 million additional doses. The timeline of the arrival of those doses is not yet clear. And it seems obviously like a large number, but one has to remember that Nigeria has a population of over 200 million. And so in effect, what we're looking at the year is just under a quarter of the population. The National Primary Healthcare Development Agency has taken the role of vaccination coordination. A slightly worrying point here is that the availability of a detailed COVID-19 vaccination plan has been difficult to obtain publicly, it seems, at this stage. That is worrying, given the fact that vaccines have arrived, and of course the pressure to begin the rollout. But we will continue to watch that space. Positive element in terms of vaccine equity is that President Buhari has been a vocal advocate for the people's vaccine and its demand to, quote, make sure that all vaccines are available in a way that's monopoly-free, mass-produced, distributed fairly, and made available to all people in all countries free of charge. And we'll come back to the People's Vaccine Initiative a bit in a few moments. Next slide, please. And of course, South Africa and commentary has done an excellent job of going through many of these points, so I won't belabor them. Maybe just to pick up one or two highlights. Of course, the 67% coverage target is based on herd immunity projections. And we have the 3 phases that commentary went through. And importantly, just to note the pivot. And the pivot with the emergence of the 501YV2 variant is important to reflect on. It underscores the need to have agility in these rollout processes. And agility then requires a certain level of logistical sophistication. In South Africa, that pivot to J&J, we were able to do. And obviously, after the first batch of 80,000, we received more, just over 100,000 healthcare workers vaccinated, as commentary has said. As a personal anecdote, my wife, who is a patient-facing doctor and occupational physician, has just gotten her vaccine now and is on her way home from the vaccination station. So this is becoming very real. And we know that there are 11 million additional doses that have been secured, and hopefully about 3 million are due to arrive in this quarter. In South Africa, we've seen a strong advocacy, certainly from government, through the presidency, for vaccine equity on the global stage. President Ramaphosa was one of the original signatories of the People's Vaccine, and that People's Vaccine, maybe just to pause there, that People's Vaccine, which was signed in May by over 140 leaders, was an aspirational document. It called for a sharing of data around vaccine, medicines, and other COVID-related technologies, the establishment of a global manufacturing and distribution plan, as well as a guarantee that vaccines would be made available to all people everywhere. Again, very aspirational, but we'll come back to the roadmap of where we've come with the pandemic now and see how far solidarity has taken us. Another element that has been very important, and Leslie is going to speak to this, is South Africa's joint proposal with India on patent waiver at the TRIPS Council of the World Trade Organization. And I'm sure Leslie will give us more information on that. Next slide, please. So let's just pull this together as we come to a conclusion. The first point is that what we've seen here is somewhat of a COVAX to bilateral drift. And by that, I mean there was, in the first instance, a great confidence, and I think there still is to an extent on COVAX, But as vaccines became available, and as countries began to hoard, and as we saw vaccine nationalism, there's been a drift towards bilateral agreements, and a mixture in many countries of bilateral and COVAX acquisition, and that's been very interesting to observe. And bilateral, I mean country to manufacture to vaccine manufacturer. The next is the need to address vaccine hesitancy. Again, commentary has spoken to this, but what we really require is an intensification of strategic communication from both from country level right down to community levels. And that is because if you look at the share of people who are vaccine hesitant, a large percentage of those are individuals who have questions that require a rational response, like the speed at which vaccines went through trials, issues around safety and effectiveness. And so to assume that hesitancy is driven purely by a large group of people who are anti vaccination is one that we need to dispel. A large number of those vaccine hesitant individuals can be swayed around to becoming vaccine promotive if we have the right strategic communication, and that then will shift from vaccine hesitancy to vaccine demand as more and more people come on board, which is a good challenge to have because that will accelerate, hopefully, acquisition processes. But a large chunk, again, of those individuals can be brought around. And there's an excellent study done by Jean Nashega, who's on faculty at the department, and he and colleagues recently released, in fact, yesterday released a great study on the rollout processes on the continent in Lancet Global Health. I'd encourage you, please, to have a look at that. The next point very quickly is around the emergence of variants. Now, variants, of course, can make a major impact, and we've seen this in South Africa, and we've seen this in other regions of the world. And I've spoken to the agility point. Another point is around the fact that because of the propensity of emergence of variants, we need to look at our vaccine coverage equation again. And we know that the vaccine coverage equation it's a very simple and elegant equation, with R naught being a function of the transmissibility of the virus, and E being the effectiveness of the vaccine to prevent transmission. And so the amount of coverage is directly related to the transmissibility. The more transmissible, more coverage you need, and indirectly related to the effectiveness of the vaccine. Both of those factors are impacted on the emergence by the emergence of variants. Variants will potentially negatively impact those factors, and that needs to be taken into account in logistical planning. And a few colleagues and I are looking at how to modify that equation using the time variable. Then I think we do need to have some recognition of the excellent work that's been done at the regional level by Africa CDC. Reflections on the COVID-19 vaccine development and access strategy will I think, be very valuable, as well as the work of AVAT. There's a provisional securing now of 270 million vaccine doses. The target, together with COVAX for the continent, is over 700 million doses. That is very commendable work that needs to be recognized. The last point before going to the final slide is on the importance of pre-existing cohesion. Now, a synthesis study done on the earlier study I mentioned that involved not just the 5 countries, but an additional 18 countries, a 23-country study on vaccination, COVID-19 vaccination, found that the assumption that a pandemic would create greater solidarity in a country is one that's faulty. What has been found is that if there are pre-existing conditions conducive to solidarity within a country, that the pandemic, in fact, would create greater solidarity. But in polarized countries, the pandemic actually drove division, and the same thing can presumably be reflected on at a regional and even global level. So the final slide, if you can, Taryn. So what I wanted to do with this final concluding slide is just share some thoughts on the journey of the pandemic and look at key periods over the last year. So initially we had the period of shock, accentuated with the declaration of the pandemic a year ago today by the WHO, the existential issues around that, the deep global introspection, the early interventions, the lockdowns, really marked that period. That quickly went into a period of solidarity, where we emerged seemingly as a global community, rallying around great initiatives like the People's Vaccine, the World Health Assembly in the same month of the People's Vaccines signing in May last year, saying that the vaccine is a global public good for health, and bookended by the establishment of COVAX, which was a critical initiative. But then we went into the period of scramble, and that period really was exacerbated by the early development of vaccines, and the realization that these have now come into the market, and the kicking in of vaccine nationalism, the proliferation of bilateral agreements, and the damage that did to the global solidarity effort cannot be overstated. Coming out of that period now, we're going into the period of rollout. We have the first vaccinations. We've seen that in the mapping, the green shoots, but more in the global north than in the global south. And with that, the uneven global rollout with a patchwork of vaccines and disparity that is quite worrying. My final point is that if we continue on this line, we go down. There is no straight line. We either go down or up from this point. If we continue with status quo, what we'll have is a condition of persistent vulnerability. And we would have had a missed opportunity. And this is important. Not only would we have the persistent vulnerability to variants circulating over and over again in the human population, but we would have missed the opportunity to come together as a global community around one challenge and build momentum to deal with post-COVID issues afterwards, again, with the same unity. And so it is a critical missed opportunity if we continue in status quo. If we do have, however, course correction, we move in the direction of a more equitable rollout. What we could end up having is a situation where we have substantive global health reform, where we do have a situation where we can, in future pandemics, have a globally coordinated response that sees not just an elimination, but an eradication of pathogens. And we can use that momentum to deal with other post-COVID or post-crises, post-pandemic issues. Thank you very much.